Good afternoon, everybody, and I would like to thank Dr. Keki Mehta to have given this opportunity to me. It's all about refitting IOLs and back complexes, what's new next year. So, whenever a new year comes, we all have some new resolution that enjoy life, get a good life balance, find somebody, lose weight, quit smoking. So, even over the number of years, I have evolved as a surgeon, and now I'm able to do much more than what I could do long time back. So, this is an interesting case which came to me, operated again by me only. Details of the old surgery don't know, okay, but we know that the IOL has got dislocated into the vitreous. We did a B scan. Yes, we can see that something is there. On indirect, we can see an IOL, but we don't know the design of the IOL. We did a specular, we did history, no history of trauma. Now, what are your options when a patient comes to you? So, one option was whatever is inside, we explant it either by cutting it or explanting it and re-implant another IOL either by the Yamane or a glued or a posterior iris claw. These are actually our options. But I did something entirely different. So this is how it was when the patient came to me. You can see that the lens, the back complex, nothing is seen at all. And I really wondered how this really happened because the lens was not in place at all. But you can see from the side. So of course I needed to put a trocar. So we went ahead and did place a trocar and then started to plan for a glued IOL. So for planning a glued IOL, yes, we need to plan all the strategy. This marker, I think, is very, very important. And you can exactly get the location, make your two flaps on two sides. And then I made two side port incisions of 0.75 millimeter. And that's it, you can see. And I started doing my vitrectomy. To my luck, the lens was just there and it came up. Okay, so the next step is to release all the traction of the vitreous from the lens. Make sure all of that is completely removed and keep holding on to the lens. The forceps I'm using is a micro grasping forceps. Now, two things you have to observe. Okay, this optic is 6.5 millimeter in size. Okay, first point. They have four holes. These are old designs. Dr. Keki must be knowing, but Cyrus wouldn't have used this lens. These are non-foldable. So you can't cut this IOL. Okay, it's a solid PMMA IOL, and these four holes which you are seeing are for, they are called dialing holes. So they are used to dial the IOL into location. Now, one more thing I want you to note that yes, now I'm holding on to the lens. I don't want it to drop back. Done vitrectomy, release all the traction from all around. And now the goal will be to bring the whole IOL in the front. Okay, what I've done is now the whole IOL is in the front. Okay, you can see that I'm bringing the IOL up and anterior. Now, one more thing I want you to note is the direction of the haptic. So you can see this direction like this and this direction like this. Now I want to glue this IOL. This direction is not the right direction. It's a wrong direction. So then what is my option? Then my option is to flip this IOL in the AC itself. So now I've got an iris repositor in one hand and a Sinskey hook in the other hand. And now I am flipping this IOL. Don't forget, it's a non-foldable 10-degree angulation, 6.5 millimeter optic with 4 dialing holes. So you can't cut this IOL. Okay, so now my angulation for doing a glue is correct. So that is rule number 2. Now the next question is, of course, do your vitrectomy and release all of that and go ahead and make your ports. Now these IOLs are very difficult to just externalize because they have large haptics. They are called J haptics. They are not modified J, which you will see in Alcon or Sensa 3-piece. These are large haptics, and that's the reason why to externalize them is little more difficult, and they can break. This rule remains the same. Now you can see that I'm just going ahead. Very important that you hold the haptic and then take the other hand for the handshake technique. And you have to hold the tip of the haptic. So you'll realize this, that I'm holding the haptic and I go with the other forceps to hold the tip of the haptic to be able to hold the tip and externalize it. When this haptic gets externalized, you can see that a huge volume of haptic really comes out because these are J-shaped haptics and not modified J. So they are larger in size. The rest is quite simple. Go ahead and do exactly the same thing on the other side and glue this. So through 2.75 incisions, I could actually bring the lens up, glue it, no issues of IOL measurement, and everything works out fine. So this technique works quite well. So refitting the same IOL was a better thing to do. Now, another case, this is all that the pupil dilates, and you can see an iridectomy. In Purana Jamana, we used to do iridectomy. Okay, now this lens is exactly the same. Now it has got subluxated. Again, we put a trocar, right? Make the flaps, thinking that we will try to refit this, but we cannot use a Melugan ring here because it gives you less exposure, or a BHEX ring. So now I'm going ahead and putting 4 iris hooks, staining the vitreous and releasing all the traction from all around. And the big advantage here is that I've got the same lens here. The orientation of the haptic is perfect. Do your vitrectomy from the side port at the same time. So the main incision at the same time also we can do vitrectomy. Once your vitreous pull is from all over is removed, go ahead and do the same technique, externalize the haptics, and again glue the same IOL back into position. So again, the take-home message here is, if your pupil is small, it's better to use iris hooks for better visualization. Make sure that all the vitreous strands which are around the IOL are freed completely. Do a proper vitrectomy, externalize the haptics, and go ahead and fit the same IOL. Now this is a little different scenario. Again, this pupil does not dilate and the lens has subluxated. And you can see anterior-posterior capsule here, fusion. I like to mark, however much experience we may be. When you want to put hooks, it's better to mark to get proper size, proper shape, a proper rectangle or a proper square that you really want to do. Now the question is, how do you centralize this subluxated 3-piece IOL? So this is to mark the center of the visual axis. And then I decided, okay, I got a little bit of, there must have been a rent in the original surgery, and that's the reason why a 3-piece lens was placed. The rest of the bag, the anterior and posterior capsule, is really fused and become one. So now what are our options? I decided that let's go ahead, make another side port and do a little bit of a vitrectomy, and then try to do an optic capture of this lens in the fused anterior posterior capsule complex. Very important to remember that the size of the optic is 6 millimeters. So your opening has to be around 4.9 millimeters. If it is less, you won't be able to do an optic capture. So you are seeing this, that I'm going ahead and trying to do an optic capture. I got the inferior optic margin inside the below the back complex, but I could not go in the upper part. So then I decided to go ahead and enlarge the same opening. Once I enlarged the same opening a little bit, here you can see that I went ahead and enlarged the same opening. Once that is done, I could easily do an optic capture. So the inferior optic margin has gone behind, the superior optic margin again has gone behind, and everything is perfect. So this IOL will never ever subluxate or dislocate. It will be captured very, very well. And this is the superior margin going behind and looks perfectly fine. One more interesting case, 14 years back, operated again by me. It was a lens called 733 and there was a lens called 737. It was made by Acritech. Acritech got bought by Zeiss. And now they make the other multifocal IOLs. It's an excellent, cheap bifocal IOL, excellent results. But there was an issue. Okay, the patient came to me like this. So you can see the pupil. Patient is allergic to sunephrine, so you can't use Drausin or anything like that. And so I use only cyclogic to dilate the pupil. And when you dilate the pupil, what you see is this. So you can see a nice round opening. So this is the lens sitting. It's a multifocal lens. And you can see a nice small round opening, which is the YAG opening. So the patient already had a YAG. Okay. Now the question is, he says that I want multifocality. What are our options? So now on the top, you can see this. This is the YAG opening. This is a subluxated multifocal or a bifocal IOL. This is one part of the haptic. We don't know where the haptics are. And this is all that the pupil dilates. So now on the topical anesthesia, what I'm doing is going ahead and putting intracameral epitrate, which is adrenaline, and the pupil dilates. Okay, point 1. Now you can see 2 haptics. Okay, this haptic is in the anterior posterior fused bag complex, and this haptic is actually in the sulcus. So now I'm putting Kenacort okay, because some vitreous was coming out through that portion. Go ahead and put Kenacort. Once we put Kenacort, go ahead and do your vitrectomy, and the whole lens complex, you can see the whole disc starts rotating. Now, once the disc starts rotating, it doesn't, it's not going to sit there. Obviously, we want to explant it, but whenever we want to explant it, it's very important that we hold the optic. So you can see that I'm going to hold the optic and then use a micro scissors to cut the optic. Now, whenever this happens, you don't need to enlarge your incision. Many times we have a tendency to cut the optic through and through 6 mm. You don't need to do that. This is one technique. Just hold the optic, use the incision as a fulcrum, and then rotate the disc outside. So you'll see that I'm rotating the disc outside and the whole lens comes out. So you don't need to make that extra effort to cut the IOL through and through. This can work quite well as well. Now, one haptic is sitting in the sulcus. Don't forget, this patient said, I want multifocality because what I was used to, right? So now the question is what to do, because we have to put a multifocal IOL. There is a YAG opening. There is two haptics lying inside. Now this haptic, I'm not going to bother. But this haptic was sitting in the sulcus, so I decided to remove that, which was very easy. The other one is inert. Don't bother about it. Forget it. Okay. Now the question is, which multifocal IOL? Do your vitrectomy again. Once that is done, put in your viscoelastic. Go ahead and put a Technis multifocal IOL 3-piece in the sulcus. Again, this lens should not subluxate. So I'm going ahead and putting the multifocal IOL in the sulcus. And then we have to do an optic capture into that YAG opening, which was originally there. And that lens will never ever subluxate or dislocate. You can see the optic capture and you can see the entrapment of the haptic. This lens always will remain perfectly in the center and nothing is ever going to go wrong. So you can see the inferior optic margin and the superior optic margin is behind the back complex and it will sit like that forever. One more case, a subluxated IOL, but a single piece IOL, right? Now, single piece IOLs, we know that we cannot leave there. So this will need a full explantation. So you can see this is again a very, very old case. We are going to remove this IOL completely. Once this IOL is completely removed, there is an opening here, which was originally there. And now we decide we can put a 3-piece IOL again in the sulcus and then enlarge that fused anterior posterior complex and do an optic capture. So these things work beautifully well. This is never going to subluxate or dislocate ever. So nothing to worry as such. A little bit about a subluxation back complex. Very interesting story. Sir, I have 2 minutes more. So very interesting story. The patient said that when I lie down, I can see, but when I'm sitting, I cannot see. So the story here is, please listen to what the patient has to say, because when you dilate, this is how it looks. So you can see the whole back complex with the endocapsular ring has gone down. So when he lies down, this whole back complex moves up. So here, what are our options? Either to explant the whole complex, do a glued IOL, do a posterior iris claw, or whatever you want. But I decided to do something different. You can see this is a pre-op image. When I asked the patient to move the eye, the whole back complex moves. You can see it move. So now the patient was taken up for surgery. We needed to put in a trocar. So when you see it on the table like this, you will wonder, it's very well centered. Why is the patient complaining? Everything is fine. But what would happen is when he sits, the whole back complex used to go down. So I'm creating a Hoffman's pocket. Once the Hoffman's pocket is created, I'm going to now refixate this back complex. I did not have Gore-Tex, so I'm using a 9O Prolene, which may not be a great thing to do. If you have Gore-Tex, it's a better thing to do. So here I'm passing the first needle from below the endocapsular ring and the haptic, okay? So very important to remember where to pass it. So remember the distance from here to here, okay? This is your optic haptic junction. This is your haptic. This is your endocapsular ring. And this much distance I have to remember as a mark. So I'm going ahead and passing the whole rail rolling the technique, the 9O Prolene from below. The same thing will be done again superiorly. So again, I'm passing the needle from above, just below the iris, from above the endocapsular ring and the haptic. So it's like holding on, looping around. Once I've done that, I'm going to go ahead and do exactly the same thing. So you can see I've now gone on the other side. From the other side, now this again is a needle pass from below the endocapsular ring and the haptic. So again, same distance, I'm trying to hold it from this distance. Here I'm going ahead and passing the railroad technique. Once I've done that, I'm going to pass from below the iris and above the endocapsular ring. So let us see when we tighten the two sides, how does it really look. I'm going to take it ahead. When we go ahead and we tighten on both the sides, you can see how well actually we are now tightening on one side, and then we are going to tighten on the other side and see how well the whole back complex really centers. So this is going to do very well over time, and we could achieve this result quite well. This is the first day post-op and works quite well. So bottom line is, listen to the patient and think of all the options and be prepared for it. So sometimes in life, things can go wrong. If that happens, you don't have to worry. There are always solutions. Only last case, very interesting. It is a posterior iris claw which I had fitted, and the patient got slapped by the husband, and that dislocated the whole lens into the anterior chamber. And the patient came to me with corneal decompensation, etc. So there was a PC rent in the primary surgery, which is understandable. There are sutures taken superiorly. We open the same suture, put in viscoelastic, bring the lens back into position, and then I'm going to refixate the same posterior iris claw, which was originally fitted onto the iris. So I'll go ahead, and this way I use a 30 gauge needle. Very simple technique. Just push down the 30 gauge needle. Don't go up down, because that can tear the iris. I just push it down, and one stroke, once you push it down and enclave the claw, once that is done, just bring out the needle and it is all sorted. So that is one simple technique of refitting a posterior iris claw when dislocated into the anterior chamber. You can refit it back, and they do extremely well. Nothing to worry. That's it. Thank you, sir. So I think it's Think Different. It really works. Thank you for your attention.